I'm J.Otis.
And I'm T-Money, aka Tommy Davis.
And this is Managing Pain in Drug Abusers.
So, although me and Justin are awesome and you guys would just love to sit here the whole time and listen to us talk, first I want to start with a question for a little bit of feedback from you guys. So, what challenges do you guys face when you're trying to manage pain in someone that you know is using drugs like heroin or cocaine or something like that?
Patient satisfaction.
Patient satisfaction, okay.
Their threshold is obviously going to be different.
Yeah.
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 The amount of chaos they create for the nurses.
Yeah.
Very demanding.
So these are all definite
Timing.
concerns, yeah, that we face when we're managing the care for these patients and their pain.
All right, so this is just a little thing we took out of an article that we found because we did use evidence-based research. These are all like legit things. I mean, me and Justin didn't make it up. We could have because we had that much knowledge.
We could.
But
Very intelligent.
so this is from the government. This is what a doctor encountered. So when choosing pain medication, the emphasis should be on using medications that provide adequate pain relief. Attempting to use less addicting narcotics may result in inadequate pain relief, which may actually precipitate a relapse by forcing recovering individuals to self-medicate with their pain. And then he talks specifically about this person. This appears to have been the case in Ben's situation, with his former drug of choice, alcohol, being used to help manage his unresolved pain. So this is just kind of to get your mind thinking, but just because they use drugs, you know, if we're not managing their pain, what do you think they're going to do? Which we may or may not have experienced last night.
Yeah, so we're going to talk about one of the first problems.
Last night.
We're going to talk about one of the first problems that we face as nurses and in this hospital is cocaine. Approximately 17 million people in the world use cocaine in 2012. And now you have to remember a lot of these statistics are self-reported or admitted or like drug-tested individuals. So this doesn't include people that haven't come forward about using cocaine or have been discovered using cocaine. So cocaine is the second most popular legal substance to be used in the United States, second to marijuana. Cocaine is thought to be responsible for up to 10% of cases seen by emergency staff in the U.S. So 1 in every 10 of our patients that come into the ER are suspected to have a cocaine-related problem. So that's definitely something that us as nurses taking care of these patients, we really need to know about this drug and what it can manifest as in our patients. Cocaine abuse was related to more than 36,000 hospitalized admissions in 2010 because it does do a lot with the heart, and it costs nearly $83 million in healthcare costs. So it's a very significant problem here in the United States. So just some signs and symptoms of cocaine use. A lot of times these patients are going to have some heart problems going on. So cardiomyopathy or heart muscle cell death. A lot of times we get our patients in with the chest pain and all that kind of stuff. Well, the thing is that sometimes if they don't fit the parameters with like having the family history and all that kind of stuff, we really need to start thinking down the track, like, was this cocaine related? Because that patient may not necessarily want to immediately say, oh yeah, I got a heart attack after I went on a binge. Endocarditis, so that's something that you may see after IV drug abuse, especially with cocaine. So these are all things that are kind of lend us towards like maybe this patient does struggle with an illicit drug abuse problem. Severe declines in health and life quality. So all these are kind of some big assessment signs that we may see, especially with the patients that come in through the ER. So in our appearance when we're doing our physical assessment, we may notice dilated pupils, runny nose, nosebleeds, track marks, and burnt lips in the patient that uses these drugs. As far as their neurological assessment, you may see euphoria, overconfidence, unusual excitement about being in the hospital, aggressiveness, paranoia, poor judgment, and delusions. These are all things to keep in mind because, again, we're talking about pain management for these patients. However, if they have not come out and told us that they use cocaine, then these are things that we want to be on alert for, because if that's the case, it's a lot easier to have that face-to-face conversation with the patient, knowing, you know what, you're exhibiting some signs. Is there any other medications or any other drugs that you use outside the hospital? And then a lot of times we may see these patients come into the hospital, especially if they can't get any more. After a long use or binge, we might see some depression, agitation, intense cravings, and these cravings can manifest themselves in numerous different ways, like food, pain medicine, even attention, and exhaustion or long periods of sleep. So these are all signs and symptoms of a patient that's been using cocaine.
Alright, so next we're going to talk about the big hitter other than cocaine is heroin. So unfortunately this statistic is from 2007. It was the most recent one we could find that was like official from the government. They said 157,000 people in the United States use heroin, but then they said, because that's people that are actually like, yeah, I'm just going to tell you, yeah, I use heroin. Or they got caught like us and said. So some estimates have it closer to 900,000, and that was in 2007, which we all know heroin's been a really bad epidemic for us lately, so the numbers are probably much higher now. But some of the signs and symptoms of heroin use are kind of a little bit more of the opposite of cocaine. So of course you get some nausea, vomiting, itching, or dry mouth. But some of like the long term, which we'll definitely see, is things like needle marks and bruising, and like where the injection sites are. Skin problems like abscesses, we see that a lot on North and South. And they'll say, I'm a former drug user, but then they have a giant abscess that is magically from a mosquito bite or something. So heart problems, liver and kidney failure, and then a lot of collapsed veins from repeated injections. So as you know, a lot of times we're trying to stick them, they have really hard veins, they're really difficult to find. That may be one of the reasons why is the heroin use. So if you have a patient who's leaving the floor and then all of a sudden they come back and they're really drowsy and like all you've given them is a Lortab, and you're like, why is this guy so sleepy? They got a slow breathing, heart rate, or they're doing the nodding. So if you're talking to them and they're just kind of in and out of it, can't stay awake, and they're alternating between sleep, being awake and asleep, that's actually a sign and symptom of heroin use. So, just something to kind of get your mind thinking. If they left the floor, they come back and they're just not seeing themselves, it may be that they use some heroin downstairs.
Yeah, so now it comes to our role in managing the care for these patients and managing the pain, right? So definitely we wanted to start out with some ethical considerations, because I think all of us have our own outlook on this, if we've ever had family members or taking care of other patients. However, as a nurse, we are required in our profession to definitely be ethical in the care for these patients. So first and foremost, the patient should receive fair and non-judgmental care. And that is probably one of the most important things, because when you come across judgmental or condescending to these patients, they're immediately going to shut down. And any chance that you have for actually caring for this patient is going to be a slim to none chance. Drug abuse is a treatable problem. I know a lot of times when we come in for our 12 hours, well, if this patient's been using drugs for the past 20 years, it's going to feel like, well, in one day at 12 hours, I can't do anything. And the thing is no, you're not going to solve their problem in 12 hours of shift. However, there are steps that you can take and start encouraging this patient and getting the doctors aware so that they can begin a road to treatment and recovery. Do not withhold options for pain management. We'll kind of go into some of the pain management strategies for these patients in just a moment, but in performing care and pain management for these patients, you are not being truthful if you do not share with them the medications that they have available to them and when they're supposed to be used and used appropriately. So like knowing which one of your medications is for severe pain and which one is for mild pain, which medication is for breakthrough, and which medications are supposed to be given continuously. You want to provide privacy for these patients. You want to really protect their confidentiality, because a lot of times if grandmama or auntie's sitting in the room, they're not going to share that they just partied for 48 hours straight and was chasing the dragon and all that kind of stuff. Your grandma doesn't want to hear that. So that means that when you're asking these kind of questions,
What is chasing the dragon? Party. Is that what party is?
It's like hallucinating kind
of.
So what that means is you really want to provide that privacy for the patient when you're assessing them. And another big thing too, just because they struggle with this, doesn't mean that they don't deserve the right to be people active in their own care. They should be given the opportunity to make decisions for their own care. And so you really need to be the advocate and facilitator of that. And do what's within your scope of practice to manage this pain. We've talked about this before many times with our nurses about the non-pharmacologic things that we can do, and really talking with your patient and discovering, what really is going on. Is it anxiety? Is it sadness? Is it depression? And they think, oh, well, I'm anxious, so I'm in pain and I need pain medicine. Communication is a huge tool that we can use as nurses, and Tommy's gonna dive into that.
Yeah, so communication is a huge strategy when controlling pain control in someone that's using drugs. So first you want to build a rapport with the patient. So if the patient trusts you, more than likely you're going to be able to control their pain better because they know that you're going to bring them what they need and they know that they can trust you. So with that being said, you want to set clear and concise time expectations. So if they're Dilaudids every 3, like we always say, write on the board, write when it's due next. Have that rapport with them, say, do you want me to bring this every 3? Especially if they've told you they're a drug addict. They have another issue on top of that, they have a tolerance, they need their pain medicine. Be mindful of your body language and facial expressions. So if you're in there and you're just, here's your Dilaudid and whatever, they know that you're getting annoyed with them. That's gonna get the anxiety going and everything else, and they're just not gonna respond to you well. Also, don't gang up on the patient with other staff. But this is very important. They, unless they're deaf, can hear us. So if you're in the halls talking about how they're a drug addict and they're just so annoying and taking all this kind of medicine, they may hear you, their family member walking by, hey, the nurses out there are talking about you, so definitely don't do that. Now, if they are a drug user and you need to tell a nurse that, do it quietly or behind closed doors, but there's no need to make the person feel like they're judging me because I am a drug user. Also, use active listening. So a good little analogy is for RAVE. So it's repeat, affirm, validate, and then empathize. And then avoid excessive negotiations. So, and we've experienced, I know I've experienced that with some of the patients. People have said, well, if you do this, then we'll give you this. That's not how it works. That's not how it should work. And that's a slippery slope as well. So you're setting yourself up for failure if you're just making negotiations. Like if you're good, I'll give you your Dilaudid. That's not how it rolls. So, and then of course, just be an active listener. So.
Yeah. So what can nurses do in managing this pain? First and foremost, I know I say it over and over again, but it's something that seems to be missed the most, is assessing the drug abuse history. Again, as Tommy had said, you need to build that rapport and everything first, but if you cannot get as accurate and as detailed of a drug history, we're not going to know what's going to work for this patient. There's a question in the assessment when you first get a new patient, and it says, do you use any drugs for recreational purposes? Sometimes you may need to be very specific, like have you ever used marijuana, cocaine, heroin, meth? Because when we say drugs for recreational purposes, they may not associate illegal drugs, or they may be so protective over it, it's like, well, they're not going to know what I do, so I'm not going to tell them. When we do know these things, you need to notify the physician of history and advocate for the patient and managing their pain. Believe it or not, the WHO and the National Institute of Health have stated that around-the-clock administration of pain medication for a patient with drug abuse history is the best way to treat their pain. You want to ask for delayed release medications or long half-lives. So that means like our MS content and our OxyContin, some of our anti-inflammatories that have a 12 or 16 hour half-life. These are the kind of medications that you want these patients on, because our medications like Dilaudid and morphine, they're going to be out of the patient's system within an hour or 2, and they have a super high tolerance, so those medications aren't going to be able to work as well for them. So if you have these long-acting medications or the fentanyl patch, you're able to say, okay, we have your extended release, and then we also have your Percocet, or we have your morphine or your Dilaudid for breakthrough pain. And communicating this to the patient does enormous benefit for them, because even though they may desire to feel the high and all that kind of stuff, what you'll notice is that your patient will start to move more. They'll start to be more active. They'll start to be able to listen and pay attention more, because even if even if they don't want to verbalize that their pain is doing better, you can see signs that their pain is doing better, and that's ultimately what we want to do, is provide the care for the patients. And then also another huge thing, if your patient does share with you that they use illicit drugs, or if there's any suspect of it, you want to ask the attending physician about consultations for pain management and psychiatry. One thing in our research that we discovered is, I kind of mentioned it before, sometimes people associate pain with other emotions and other feelings. And so if someone who's very anxious or someone who's very depressed, they say that that's pain, we as nurses, it's not within our scope of practice to differentiate the two. However, someone like a psychiatrist can say, you know what, let's redefine what pain is to you. And let's redefine like what exactly is going on so that we can truly help these patients get better and manage their pain. So the last three things are the things that we want you to take with you. The first table is the WHO definitions of physical dependence, tolerance, substance abuse, and active addiction. So it's extremely important to know the difference, because someone may be abusing a substance but not an addict. And so that's something that we need to be careful when we verbalize this between each other and to physicians, because we don't want to use the wrong words to describe a patient. The second one is the WHO recommendations for escalation of pain management. And so you'll see, recommendations for mild pain, moderate pain, and severe pain. And then the last is just general things that we can practice when dealing with someone who is having problems controlling their pain because of substance abuse.
So, and when we were doing our research, basically one of the main things we found that they all recommended was that the around-the-clock pain medicine with the extended release. So, we know a lot of times, especially if they are addicted to drugs, they like that Dilaudid, that rush. But even if they say it doesn't work for me, just see if you can get them to take it, because whether they know it or not, they may think it's what you're pushing in them that's helping them. But that extended release is going to help them a lot too, and especially the anti-inflammatories, depending on what's going on with them.
Yeah.
Toradol does wonders. Now they might not think it does, but like we said, use it in conjunction, and yeah.
Make a big difference. Any questions?
That was really good.
Okay.
Thank you.
Yeah, thanks for it.
Great job.
And don't forget to take your post test and just write your name and your unit on there.